This is Dr. Win. I'm a general dentist. Just want to share with you guys, for especially those of you guys are thinking about general dentist, thinking about doing braces. And I'm just trying to help you guys to understand the concept of uh, what to know before you start braces. So let me just go back and just want to share with you. Again, a full disclose, I'm a general dentist. I've been practicing dentistry for more than 22 years. The purpose of presentation today is not to dictate um, or teach you guys, but share what my experience in doing general dentist, doing braces. So just to give you a little bit of background, I took some 2-year orthodontist residency program up, sort of like a mini residency program called Progressive Orthodontic Seminar um, by Dr. Don McCann. He retired already, but he's amazing dentist. He invented, it's called the individualized orthodontist practice, and it does have a lot of torque, help to move your teeth, move patient teeth, whether you need to move the root or the crown, buccal, lingually. He had that amazing tool, practice, individual practice that is so powerful, help your patient significantly. That's what I learned. I learned almost like uh, 2010, I believe. So that's 15 years ago already. And I've been starting with basis braces first, and move on to a little bit more um, from minor case to a little bit more to the moderate case. But for those of you who start braces, this presentation is mostly for the international dentists. I don't know your country, what exactly the requirement is, but just to share the basic concept of what you should know before you start braces. With that said, go ahead and share. The first thing I want to share is the case selection, guys. Case selection is all most important things. Um, if you can start with a very minor case, uh, little space, less than 4 millimeter, whether it's upper teeth or lower teeth. Those are great opportunity to learn. Start with very basic procedure like that. So minor crowding spaces, those are predictable. Avoid skeletal discrepancy or complication, complex malocclusion. You're not able to do that yet. You have to start very basic. Mm, and use full diagnosis record before deciding to do it. Of course, you need to have a mentor. So you go to a mentor. You can't do dentistry without a teacher, a mentor. Start with a training. Get yourself a local um, mentor. Mm, Myself, I have at least two orthodontist friend. One is a very long-term retired uh, orthodontist, and then also I have my best friend is the orthodontist. So he worked in different states, helped me to connect with him, and always ask questions before I start. So at the beginning, it kind of like, scary. You don't know really what to do, but think about it. Orthodontist is really about the movement of I mean, 1 plus 1 equal 2, 2 plus 2 equal 4. A very basic concept of mathematics and basic vector and physics application in real life. If you're able to pass the physics class, orthodont, and then math class, and I'm sure you can start with some basis, minor crowding spacing. Again, avoid skeletal discrepancy, complex malocclusion, and make sure you got full diagnostic record. What does that mean? Well, it requires um, intraoral photo, and photo of your patient, and care study model, panel, ceph. If you do any of those complicated procedure, you must have full record just to study yourself, right? To learn how it works. So, by the way, I use some of those record through online. So, just to give you the idea of multiple different kind of record that you can obtain, panel, ceph, um, and cast, 3D printer, video, photo, all those things is really important to help you to keep the record, help you to learn what how patient changed, grow. And so the second thing you want to learn is you need to understand the grow and skeletal pattern. Um, you have to determine if the patient is still growing, whether the patient for boy is if you do any teenage from 13 years old to 19 years old, they still have a chance of growing. This boy can grow up to 20, 21, 22, 23. So there's a chance of growing. But for girl, usually they stop growing around 16, 17, 18 max, So they have a slower growing period and faster growing, but then they stop so quickly early. And so you need to understand the growing. If you treat young kids, there's a lot of potential growing. So don't look at the kid like when you treat kids under 12 years old or at a teenage age, there's a lot of grow, unpredictable growth. So you make sure you calculate that into your diagnosis and don't over treatment plan. For example, remove too many teeth and all that stuff. Weight, you gotta be careful. Make sure you study. Ask your mentor. Go through the classification: class one, class two, skeletal base, occlusion, class one, class two, class three. Identify the vertical pattern and asymmetry. All those things are really important. Need to know that. And also, comprehensive diagnostic. I mentioned to you, you gotta understand the facial aesthetic, smile line, evaluation of patient when they talk, and dental alignment, occlusion relationship. Get the record panel, ceph, photo, model. All those things are important. Depend the where do you practice, right? So in general, occlusion principle is really important. And then understand the angle classification, functional occlusion. You got to understand the bite. Otherwise, you can't do dentistry. Whether you're a general dentist and orthodontist, you need to learn how to understand the real occlusion function. Uh, Planning, ideal finishing occlusion, or just straight teeth, right? What exactly you want to accomplish, what your goal. You got to ask that question. You got to work with the patient. What expectation do they have? And understand, review your centric relation and centric occlusion. I just want to touch on this really quickly because it's important for when you do braces or practice orthodontist or general dentistry. This is deal. So, relations is basically we're talking about the condyle in relation to the fossa of the skull, right? So it's a relationship of the jaw. Okay, in the mandible is position with the condyle to the most anterior superior position of the glenoid fossa, resting again the articular eminence where the disc that properly interposed. It is a reproducible and muscular skeletal stable position. used to for reference of restorative prosthodontist and occlusion analysis. Now, when you see these patients that have the teeth move running around a lot, especially in those teeth where the teeth worn out, you have to be careful because there's no tooth anatomy, there's no intercuspation relationship, uh, which is the next term is called the centric occlusion. Basically, the tooth relationship is the dependent on where the tooth actually meet, right? So if you got a worn out teeth, you will have a problem of intercuspation process because you can't reproduce. Everything moving, especially the upper and lower teeth are worn out. So you make sure that you have the refer to the so when you have the term, it's called maximum intercuspation precision, MIP. That the modern term is basically when you have a good reproducible central occlusion, and that is something I want to touch on. So, what is it really in dentistry? Well, in occlusal clinical relationship between centric relationship and centric occlusion is very important. In in most patients, the uh, uh, centric occlusion, which is the maximum intercuspation, occurs slightly anterior and superior to centric relationship. This is called a centric slide. It's typically 1 or 2 millimeter different. In a harmonious occlusion, patient has a smooth transition from CR to CO without any reflex interference. So it's really important for you to understand that in the uh, clinical importance of CR and CO in prosthodontists, all complete denture case are make in centric relationship because you relate to the jaw, right? There's no more teeth. But in orthodontic and restorative, you understanding that the centric relationship and central occlusion discrepancy is crucial before major treatment. You move teeth, you change everything, especially canine and molar, first molar, then you will end up having TMJ and occlusal instability. So make sure if you treat adults case or teeth that worn out a lot, you really have to discuss with patient about their problem already to begin with. Otherwise, you run into a situation where um, patient may not be happy with the results. Again, the fifth thing I want to touch on is the periodontal, periodontal and oral health. You cannot treat the patient, whether it's a young patient or adults, when you have unstable uh, gum condition. So make sure you check the bone level, recession, wrist and frenum attachment. Those attachment need to be released, whether it's released before or after braces. You got to discuss with the patient the bone level. You got to respect the bone if there is no bone, right? So nowadays we have 3D for 3D imaging, 3D X-ray, CT scan. This does help a lot. Require an excellent oral hygiene to before starting. Without excellent oral hygiene, you can get yourself in trouble. So make sure that what does it mean? Because if the patient if you move the patient teeth and uh, tartar and plaque build up, gum disease occur, tooth can be very mobile and can fall out. So the gum disease can be very aggressive. There is a risk of periodontal disease. And also, there is some certain adult case where patient have localized periodontal or deep pocket because of the malocclusion. And that is something that you at the general dentist, if you can eliminate or refer to have it discuss with the periodontist whether how you can work in conjunction to make sure that patient aware that these, where especially at the bicuspid, maybe potentially need to be removed if they the need of fixing the bite. So remove those bad teeth before you even start it, or letting the patient know that eventually one of those teeth had to be removed if you work in an adult case. So in the future, we'll share with you some of the very interesting case that, if you know what you're doing, you can accomplish not only perio and ortho together, but that's required a lot of experience, confident, and understanding perio and ortho and prosto all together. It's if you just simply focus on your mind on, can run into a problem. Again, sixth thing is biomechanics and tooth movement. If you don't understand how the mechanical movement of the teeth, for example, tipping toward bodily movement, the whole tooth movement, you taking risks, right? I'm talking about my moderate to severe case, you got to understand how you move your teeth, move teeth movement or tooth movement. So you got to respect the alveolar bone with limited to prevent damage, right? Uh, Thin biotie gum or thin alveolar bone, all those things are very important. And understanding the ratio, crown ratio of the tooth, and especially those patients who have very short root, be careful, very careful. Or patients who already start braces once time, they have root resorption. Those things are very crucial. So spade maintenance, spade management is the next things is plan to for if you plan interproximal reduction or expansion or distalization, extraction. Gotta understand the whole math and face it part. um, anchors, manage anchors, very important. You don't want teeth move forward and create a collapse bite. Keep crowding goal realistic for alignment case. So those align, a lot of people who do Invisalign, you got to understand the limitation that you can't move much with if you do aligner. Retention, number a retention. um, Retention plan and decide what type of retaining for the patient before you even start brace. If you could, if you understand the whole concept, you see the picture before you start. Educate patient lifetime retention needed. Sometimes we might have to put a fixed retainer. Sometimes you have to do a fixed retainer for now, and removable retainer. Plan for follow up. Make sure you follow up the patient. Although is very important with follow up. Um, Understand the moral, legal, ethical boundary. You understand who you are, whether you're comfortable with certain kind of limitation that you have. Make sure you got the record keeping. And lastly, knowing when to refer. That means that you have to be friend with your local orthodontist specialist, oral surgeon, endodontist, periodontist, especially when you involve with complex skeletal TMJ case, impact to severe rotation, and non-compliant and poor oral hygiene patient. These are patients that can give you a lot of trouble. That's the reason why if you begin to start doing ortho, I like to go back to the first slide. Is you should start with very basic one. Don't go too complicated one, guys. Start with basic contest, and that's why I say get the mentor. These are 10 things that I just want to share, and hope that you enjoy my presentation. See you next time for a deeper conversation. You guys have a great day. Bye bye.